Welcome to Talking Meds on the PrescQIPP podcast, engaging conversations about medicines-related dilemmas. I'm your host, Jonathan Underhill. Hello everyone. Welcome to Talking Meds. I'm your host, Jonathan Underhill, and today I'm joined by Dr. Lucy Pollock. This is the fourth in a series of podcasts on sensible prescribing in older people with Jonathan and Lucy. So we're going to continue our conversation, aren't we, about sensible prescribing in older people? And one of the cases that I come across all the time is the management of chronic heart failure. We talked last time, didn't we, about how do you manage heart failure in people with preserved ejection fraction. But I think you've got a story about a lady with reduced ejection fraction, haven't you? And we can talk about what the best things to do there are.
And it's such a familiar picture to anybody working in primary care, to geriatricians, to people working in acute medicine, to pharmacists looking after those patients. We know that in England and Wales, every single month, about 6,000 people are admitted with acute decompensated heart failure to hospital. So that's huge numbers. And a lot of those people are older. The average age of those people who are admitted to hospital is about 78. And a lot of people are older than that. So it's a really thorny one. And it's also one where we come up against that classic thing of an algorithm and a guideline and looking at that and thinking, does my patient fit? Where does my patient fit into this guideline? Is my patient described by this treatment plan? So it's a really good one. So one of the people I've been thinking about is Janet, and she is a lovely 86-year-old lady. She's a retired teacher, and she came into hospital. Actually, she'd had a hip fracture, fallen over, got a hip fracture, got breathless and hypoxic post-operatively, had signs of heart failure, had a BNP that was off through the roof, and subsequently had an inpatient echo. So it was all very good management, and it showed, yes, indeed, she's got a reduced ejection fraction. And to be honest, there's no real surprise there because Janet's had heart attacks in the past. So she is one of those older ladies who doesn't have preserved ejection fraction. She has got reduced ejection fraction. So, there's some fairly obvious treatments that we are immediately drawn to.
It's the 4 pillars, isn't it, Lucy?
That's exactly it, which sounds a bit like a religion, really. So just thinking about what those 4 pillars are, an awful lot of people with heart failure need a diuretic, which is usually a loop diuretic like bumetanide or furosemide, to help clear off the fluid off their lungs and their legs. Those aren't among the 4 pillars. Those haven't been shown to change prognosis, although they clearly make people feel much better. But separately, the 4 pillars are the use of a beta blocker, usually a cardioselective one like bisoprolol, for example, together with a mineralocorticoid, which would usually be spironolactone, although sometimes a clarinone for some people, together with an SGLT2I, that's one of those sodium glucose things like a dapagliflozin or any of the other gliflozins, which, as we mentioned last time, don't cause the glucose to flow in. They are glucose flows out, is how I remember them. They make you pee out sugary urine, and the water follows that. And then finally, the 4th pillar is almost 2. It's either an ACE inhibitor or an ACE inhibitor, an angiotensin receptor blocker mixed with a neprilysin inhibitor, which is sometimes called a combination called an ARNI. And the classic one that's licensed of that is Entresto. So that's actually 2 drugs in one. But basically 4 pillars, those are the big treatments for heart failure.
So, Lucy, just to be clear, in the NICE guideline on chronic heart failure with reduced ejection fraction, it might not be clear from first look where the SGLTs fit in, but it does say in the guideline that there are technology appraisals that have been done on both dapagliflozin and empagliflozin that NICE assume will be considered as part of the recommendations in the guideline. So they are in there as part of the, if you like, the 4 pillars or the 5 pillars. So you should still take those into account when you're considering the options available to people.
actually, the other thing is that quite often when you've got somebody onto those 4 pillars, you can often wean off the loop diuretic, because in fact their heart failure really does improve. We see improvements in ejection fraction with those treatments, and people end up often not needing the loop diuretic, but that's not true for everybody. But the hitch is, who should we be giving these 4 pillar medications to, because they are not right for everybody. And the big question is, are they right for Janet? Is Janet somebody who would have been in those trials of those important medicines? And is she going to derive benefit, or may she be somebody who might be more likely to be harmed? And this is a really thorny question.
So I have lots of conversations with colleagues who work in primary care where their patients are discharged from hospital with heart failure on the 4 pillars, if you like, of therapy, and a lot of the prescribing has been done, as you said, almost by rote, by just following the protocol and following the guideline. And they'll often say, well, that's what the NICE guideline says for us to do. And there's a quality standard. Then if we don't do this, then we're going to be in trouble because we've not followed the quality standard. It's probably worthwhile reading the quality statement that from NICE on the heart failure guideline, and the one about medication. So this is quality statement 3. And it talks about the medication for chronic heart failure. It says, adults with chronic heart failure who have reduced ejection fraction should receive all appropriate medication at target or optimal tolerated doses. So the important words there are appropriate medication, not everything to everyone, but appropriate, and optimal.
Yes.
So what is optimal? And that therefore has to be personalised, doesn't it, Lucy?
You've absolutely hit the nail on the head. And this is where it starts getting complicated, because when you look at the big trials, you look at, for example, the average age of the population in those trials, mainly in their 60s, and almost exclusively, or certainly in the majority, men. So when you take evidence that is extrapolated from a trial data that is derived from men in their 60s, and you apply it to an older lady or man who's much more frail with multiple conditions, you cannot be surprised when you run into trouble. Now, that does not mean that she's not going to get benefit, but it does become much more difficult to work out whether she's somebody who's going to be harmed. The other thing that we know is that these medications aren't always very well tolerated. So, for example, in the big trial of the neprilysin inhibitor done in 2014, they actually had 2 run-ins, and they lost 10% of their patients when they were only taking the ACE inhibitor part of the run-in, and then they lost another 10% while they were taking the trial drug for 2 weeks before the trial began. So that meant that 20% of people didn't tolerate that medication before they even began the trial. And those patients will have overrepresented older, frail people who are more likely to run into trouble with hypotension and AKI. Yes.
So the point about that is it's just not relevant to everyday clinical practice, is it? Because you don't do that in your everyday clinical practice. So the people in the trial aren't representative of the people who you see in your clinic, or you see in primary care, or indeed you see admitted to hospital with heart failure.
Exactly. And yet we don't want these older, frailer people to be denied treatment. So the question is, can we treat them safely with these medicines? So the other thing we know is in the trials, they're very, very carefully supervised. They have very frequent blood tests that could be quite difficult to replicate in primary care. And then obviously some of them do not tolerate the medicines and they have to come off them. And sometimes you just have to accept that the patient cannot tolerate that. And that's fine. Don't make them have it again. If they've got symptomatic postural hypotension or that they're developing AKI, stop the medicine and let them off it, because they are in that group of people who can't tolerate it. That's absolutely fine. The other thing to do, though, thinking back to Janet, is let's have a bit of a think about what else is going on in her life. So Janet's husband died a year ago. She's living on her own. She is desperately lonely. She's developing cognitive impairment. She's been referred to the memory clinic. They haven't seen her yet, but actually, if you speak to her family, everybody thinks she's got dementia, and probably Janet herself thinks she's got dementia. And my general rule is if the family thinks somebody's got dementia, they probably have. So there are issues now for her with her cognition. She's got chronic kidney disease. She's had episodes of AKI in the past. She's had previous falls and fractures, and she's very prone to getting postural hypotension, which we know predicts dementia and is associated with dementia. So we've got other things going on in her life. And then we can have a look at her medication list and think, blimey, Janet, how are you managing that little lot? Because we look and we see felodipine, because she's been hypertensive for years. She's got isosorbide that she's been on because she had angina a long time ago. She's on a DOAC because she's got AF, and she's on cloppy because she had an MI 12 months ago. She's on a statin. She's on alendronic acid. She's on a big fat Accrete D3 tablet, which I'm sure you've seen, Jonathan. It's about the size of a pessary. You look at it and you think, what end are you meant to put that tablet? Yeah, horse pill. She's on the digoxin for her AF. She's on frusemide because she's got their heart failure, paracetamol and codeine, some laxatives that when you look a bit more closely look like it's mostly docusate, which we know on the whole doesn't work for opiate related constipation, and she's got some nicorandil as well. So she's on an enormous number of medications. So before we even start thinking about, okay, can we do something with your heart failure, why don't we start by deprescribing some of the stuff that isn't helping? So
so and again, completely right. For some people, that's a lot of medicines. For most people, that's a lot of medicines. I guess the question is, how well is she coping with taking all those medicines? Yeah. And it might be that she's coping really well with it, and she's got a sort of a regimen and a sort of her days planned out around when she takes the medicines, and that might be fine. But we need to ask her that, don't we? We need to find out, and we need and there's techniques you can use to find out those sorts of things as well, by saying things like developing that sort of empathy with the person that says, I forget to do things all the time. How on earth do you remember to take all these medicines? And it might be that she then says, well, actually, sometimes I forget. And that's when you can explore the potential for safely reducing some of them.
Yes, that brilliant technique of Deb Gompert saying, please, can you show me your medicines? I love seeing people's medicines. And you're right, she may have them all in a biscuit tin, all in a really neat order with a very good list that she ticks off every day, but she may not. The other thing is, actually, are they actually doing her any good? Because when you ask Janet, do you still get angina? She will often say, I haven't had angina for years. In fact, I don't think I've had angina since I had the heart attack, which is actually quite common. If you infarct a bit of muscle that was causing angina, you don't get angina anymore.
Yeah.
Or if you're not moving around. So there you can immediately lose the isosorbide and the nicorandil. The felodipine needs to go because she's got heart failure, so it's relatively contraindicated. She's got postural hypotension. So let's get rid of the antihypertensive calcium channel blocker. It's not doing her any favours at all. So we're already reducing them. The Accrete, there's an easy move. We can change that to a 1 a day Thecal tablet, for example, or any preparation that's melt in the mouth 1 a day, doesn't need to cause you so much trouble. And we could even think about switching her digoxin that she's on for atrial fibrillation to bisoprolol for rate control, and there we've got one of her 4 pillars is in there already. So that might be some simple moves that would just clear up her medication and make it more effective. But then we need to think what else is going to help here. So then it's your conversation, which you always come back to, Jonathan, so wisely. You say, what matters? What are her values?
Yeah. So not what's the matter with you, but what matters to you. It's that key phrase that just enables that conversation to take place.
Yeah.
That and again, it requires you to have developed a relationship with the person to get that candid honesty from them. But that's what we're trying to get at here. What is it that makes you tick? That's a priority that really matters to you.
Absolutely. I love the question, what makes you smile?
Yes,
and so often you get a smile, and I can tell you, because I asked Janet that, and she immediately smiled, although there were tears in her eyes as well. My little cat cat Pepper, and that is the only thing that really matters. She hasn't got children, her husband has died. She's actually desperately lonely. She speaks to her husband during the day, every day, even as if he was still there. And she is very isolated because she can't get out of the house anymore because she's got so many mobility problems. So then suddenly we're into a conversation about the future, because I want to do a bit of treatment escalation planning with Janet. She hasn't even got a resus decision yet. Now, a resus attempt would be completely inappropriate here, but nobody's ever broached it. So let's have that gentle conversation. But while we're having that, and we can talk about that another time, the resus chat, but it's so lovely if you can do it as part of a prescribing review. because it's about what matters to you and what's important.
Yeah.
And actually, what she's really worried about, she said to me, I know I've had a heart attack before. I could go any time, and what will happen to Pepper?
Yeah, absolutely.
So, well, that's a lovely
I've
conversation.
I've had similar conversations as well, where people say, and it disarms you actually. They say, you know what, I've had a good innings.
Yeah.
And actually, my husband's died now. I'm at the I know I'm towards the end of my life, and actually, it's about what a good exit would look like almost in some
Exactly.
ways.
And people are
And
so courageous.
it's a really difficult conversation to have, Lucy, but it's really it happens to us all, and we don't talk about it. It's brilliant.
And do you know, I'm
amazing.
not. Yeah, I mean, we bill it as a difficult conversation. In fact, I think it's one of the most rewarding conversations you can have, because people actually, they're thinking about this quite often. They just don't dare say it, and they don't. They don't want to trouble. If they've got family, they don't want to trouble them with their fears. And actually, it's a really precious conversation, and it's such a relief. So Janet and I had a lovely chat, and we organised for her to meet the Cinnamon Trust. And I don't know if they're great. They operate nationally, and they will come and see somebody and help them make a plan for what's going to happen to a treasured pet after they've gone. And you might have something different in your local area, but have a look and find out what's available. Because my golly, the idea that that somebody's going to look after your sweet little cat when you've gone, fantastic.
Yeah.
Then we can make a super treatment escalation plan about what she does and doesn't want. And then we can also go back to that question about what other medicines are going to help for you. So once we've cleaned up this horrible, messy looking drug chart, taken out a whole lot of stuff that isn't making any difference, then we can start having a conversation about, right, is it a good idea for us to try? We've got the bisoprolol in there. Would it be a good idea to try that ACE inhibitor? If it wasn't one of the things that caused her kidneys to disintegrate last time, then maybe that's a good idea. Really cautious because she's had postural hypotension, so I'd be very wary about it, but it doesn't mean it's the wrong thing to do. But you just have to go in with your eyes absolutely wide open. What I would not do is there's a big trial called Strong HF, which is a lot of people will have heard about, and it was a concomitant initiation and rapid up titration of heart failure medicines, done in very controlled situation in hospital prior to discharge. And at the moment, a lot of people are being put under pressure to do that, get somebody onto all those medicines at once, get them up to maximum doses. Please don't. We are going to run into trouble if we do that. One of the exclusion criteria for that trial was age over 85. So Janet would never have been in that trial, and nor would lots of other people with frailty. So just go really gently. Don't feel bad about starting these medicines one at a time, and being very careful, and be very ready to stop them if they're causing trouble.
Yeah, but it's that enabling question that's really important here. The thing about Pepper and the cat is the thing that sticks with me. And I'm reminded there was an article in the New England Journal of Medicine in 2018, and it's called "The Name of the Dog," and it's by a junior. Well, he was a junior doctor at the time called Temur Safdar, and it's a really lovely little just narrative piece, and he talks about how he's doing the morning rounds, and he says, I presented a patient who was admitted for chest pain after walking his dog. My attending physician had asked, what's the name of his dog? And he says, I was stumped. Worse, I didn't know why we needed to know. Nowhere in the books or in the studies I'd read had a dog's name contributed to the differential diagnosis. But the attending took us back to the patient's bedside and asked. Rocky, the patient said, and there followed a brief conversation that was more colourful than any other I'd had with the patient that day. It led to a transformation I did not fully appreciate at the time. There was an actual person behind that hospital issued gown. 4 years later, I'm not sure anything I've carried from residency has been more useful than that question. Isn't that brilliant?
That is such a lovely article, and it is so true. The reason you and I are smiling is we've been in that situation, and lots of other people listening will have been in that situation, and these are such important moments. You catch them and suddenly you're onto what's important, what matters, and we frame our treatment around that. It's magic. So I think there's lots of good things we can do for Janet, but it goes beyond the 4 pillars.
Yes.
Janet needs a wraparound, and it doesn't have to take forever. It doesn't take long. These conversations, as that article said, it was a brief conversation, but it was transformational.
Absolutely.
Because suddenly you've got what matters to your patient, and you're on the same page, and all the rest of it all falls into place once you've done that.
And it's guidelines, not tramlines, Lucy, isn't it? It's guidelines, not tramlines. The clue is in the title. As David Haslam, the former chair of NICE, said, these are not recipe books to follow. They're to guide your practice in a conversation with the person to find out what's important to them and prioritize according to what matters to them. And if you don't know what matters to them, you've got no chance.
Yeah, just ask them. Just ask them. You'll find out. People will like telling you the story. I think we should leave it there. We've covered a complicated subject. We haven't given you all the answers because there isn't a correct answer for Janet. No. There is a way of feeling your way to what suits her, what's right for her. The optimal treatment will be individual for her, and it'll be different from the person that you see next. So, but all power to you, because this is where medicine gets really rewarding. This is why it's not being done by an algorithm. This is why you are not going to be replaced by a computer, because you're going to ask the other question, like, what's the name of the dog?
Absolutely. Really good. Okay, lovely, Lucy. Thanks very much. See you again soon, guys. Bye.
See you soon. Bye.